Sorry, otherwise, just noticed. Good afternoon, everyone. It is my pleasure to introduce Dr. Deborah Cook. Dr. Cook is a distinguished professor of medicine in the Department of Medicine and Health Research Methods, Evidence, and Impact at McMaster University. As academic chair of critical care medicine at McMaster, she also holds a Canadian Institutes of Health Research Tier 1 Canada Research Chair in Intensive Care Medicine. Dr. Cook is a frontline critical care consultant at St. Joseph's Healthcare Hamilton. She has published over 800 peer-reviewed articles based on advanced life support, preventing complication of critical illness, research ethics, and end-of-life care. Studying the challenging ethical frontier of death while dependent on technology, Dr. Cook developed the Inspiring 3 Wishes project, adopted in many hospitals around the world to elicit and implement personal wishes of dying patients to honor their dignity and celebrate their lives. As a founding member and chair of the Canadian Critical Care Trials Group, the Deborah J. Cook Mentorship Award was created in recognition of her mentorship to students, trainees, and faculty focused on critical care illness. Dr. Cook has received numerous national and international honors for her scientific leadership, including CIHR's Gold Leaf Award for Impact and Lifetime Achievement Awards from the Society of Critical Care Medicine and the ATS. For her enduring scientific contributions to the improvement of intensive care worldwide, Dr. Cook was appointed an officer of
Probably the guy.
Dr. Cook's presentation today is entitled Compassionate End-of-Life Care, the 3 Wishes Project. Please join me in welcoming Dr. Cook.
Thanks so much. I want to thank Dr. Gershengorn for the invitation to come today. I know this topic on end-of-life care is something we've been thinking about a lot over the pandemic. And it's always been a special sort of focus of my practice and a feature of my own teaching that I've really enjoyed. So the objectives today are just to reflect on some of the challenges of end-of-life care in a technological world and reflect on spirituality at the end of life, something that we don't talk about very often, and encourage some conversation about the potential for compassion in our practice. So as all of us as individuals or citizens out in the community, they're in yellow, we are persons, we are citizens, we are individuals. We have a large group of people around us, small or large, but different communities, shall we say, our family, our friends, workmates, other community members like folks at the gym, people in our place of faith, etc. When we get sick in hospital, the patient instead is surrounded by a large number of individuals, different professional roles ranging from occupational therapists to respiratory therapists, and pharmacists even, and the family members and other individuals such as our friends and people who might be in our sort of circle just become grouped together as visitors. We have visitors rules, visitors guidelines, visitors hallways, and these people obviously are not the individuals who surround us most often. So many years ago, Francis Peabody had some wonderful touchstone statements I've always appreciated, reminding us of the essence of patient care, the essential qualities of the clinician, his interest in humanity. For the secret of the care of the patient is in actually caring for the patient. And when we are surrounded in acute care or step-down units, in the operating room, the intensive care unit, by a large amount of technology, which is growing like there's no end in sight, it's often hard to know, is there a person in the bed? And we come to know less and less about them. Lots of statements have been written about this, especially from the ICU. And at the end of life, just over my years of practice, I've been thinking about ways to try to enhance the dying process, not necessarily in a randomized clinical trial, but just to try to make a difference in my own backyard and think about ways to try to humanize the process and support family members in grief, those ones left behind after our patients die. For clinicians, always we're looking to inspire a deeper sense of our vocation. It's been challenged intensively in recent months. And so the premise of this project was simply to elicit and try to implement or fulfill personal wishes that may bring comfort to dying patients or the families in their final days or hours. And it all starts with a conversation, getting to know people a little bit better beyond their lab tests and everything we have in them or on them, and many, many of the interventions that we utilize. So the wishes can be those of the patient, the family, friends, or clinicians. And some of them, and I'm sure you've all had experiences like this. This is one of our patients who just wanted to go outside in the middle of March. There's no snow, ironically, in Hamilton in the middle of the March this particular day. But it was a patient who was out with his partner, his brother, bedside nurse, respiratory therapist. And the specificity of these wishes is what matters a lot. This patient wanted Diet Coke, not Diet Pepsi. It wasn't just any song playing in Tom's red iPhone there on the left. It was a special song, Harvest Moon. It wasn't just any kind of bed sheet. It was new white hospital sheets and a special blanket to come. That is what he wanted. Other simple wishes are gathering of families, breaking the rules a little bit, maybe having a favorite beverage, bringing in the family pet. And we all know family pets are sometimes most important members of the family, most well loved. And telling stories, a map, an old-fashioned map on this patient's bed, telling tales of travels with a large family in the final night. Some patients are awake and able to express what matters to them most. And this gentleman loved the sad Hamilton football team, I might add. And it was just delightful to receive a number of gifts and memorabilia from the Hamilton football team once it became known that that was what would mean a lot to him in his final weekend before he passed away. We always talk in medicine about the ABCs of resuscitation. But as Max Tuchanoff has often said, attitudes, behaviors, compassion, and discussions are the ABCDs of dignity conserving care is something we often forget. And what I've seen over my career is more and more technology used to good effect, very often very helpful. Humanism, a little bit more threatened in healthcare. And one of my goals has been always to recognize the inherent dignity that everybody has. Ours, we don't give dignity away. We got to recognize it within the people that we care for. And this part of my practice, we just thought, how about we try to formalize it a little bit more? And we developed this program evaluation with qualitative data collection, asking family members after their loved one died, asking clinicians caring for deceased patients, and even some managers in units in which I worked, and clinician focus groups. We matched that with some quantitative data just to describe the patients, whether they had high flow, low flow oxygen, non-invasive or invasive ventilation, and characterize the patients and the families, etc. And through the interviews, we had some incredibly powerful statements, and I'm sharing these photos as well as these reflections with permission, of course, through Research Ethics Board's approved protocols. And you can see this daughter said it totally changed the focus of a negative experience into a more positive experience toward the end. We were able to focus on who my dad was versus what was actually happening to my dad. These wishes are myriad. They are simple. People often ask what they cost. 80% of them cost nothing. Humanizing the environment, taking all the stuff out of the room that isn't necessary, putting down the guardrails, bringing in special sweaters from home, music, rituals, secular, religious, any kind of rituals, paying it forward, offerings that people bring to try to make an awful time a little more pleasant, bringing in tea and coffee for those sitting in the room, flowers, celebrations, and tributes. And through this study, which was really only a demonstration project, we found that this approach to personalizing dying, and it was initially in the ICU, helped to recognize the inherent dignity, of critically ill patients, gave voice to the family, something they could do, something they could request, something they could do that's honoring or celebratory. And it really helped to call forth clinician compassion. And so this went on, and other centers began to practice like this. And many people, I'm sure some of you here, already do this kind of thing or recognize that it is going on in your environment. So the Three Wishes Project was not a build onto, but rather an integrate into and giving a name to that which is done sometimes. One of the nephews who we interviewed really encouraged us to keep going. He said, full steam ahead, never give it up, because if you give it up, then you're just going to be a standard hospital and nothing extraordinary will come from here. When something extraordinary is in the making, you don't give it up. So when we finished this little demonstration project that was published in Annals of Internal Medicine, I think because it was so evocative and resonated with the humanists in clinicians, I was trying to think about what really is a wish. I've given you examples of what wishes could be, but the act of eliciting a wish is a process, and of course the wish itself is a product, but there's many different conceptualizations of this activity in practice. A way to show your shared humanity, a therapeutic connection in action that may be hard for some people to express in words, a transitional activity that can help people, expressions of empathy that are tangible and therefore acts of compassion. It was many years into my practice, I'm embarrassed to say that I even understood the difference between sympathy, empathy, compassion. And Shane Sinclair, one of the Canadians from the province of Alberta, had worked on his PhD with some family members and patients who had cancer, who helped to discern from the patient's perspective what the differences were. The sympathy may be verbal, acknowledging suffering. It has an intent to offer a great response, but sometimes people may feel pitied or patronized. An empathetic response is more emotive, emotional, verbal, but also effective. And while again, the intent is so positive, it tends to be have a more, shall we say, favorable response, where the patient in this case would tend to be more heard and validated. But the highest form of engagement in this sense is compassion, which is more action oriented, and again is meant to ameliorate the suffering, but tends to do so and actually can have the outcome of improving well-being. And thinking about this on the continuum, we talked in our community about the role of compassion. And this often comes up, as you know, in busy hospitals when there are learners, interprofessional learners and like-minded colleagues. And through our projects in our residency training and fellowship training program, some of the touchstones were sort of highlighted here. Not when you're talking to someone, not rushing, not walking by a family, we pay attention to our language, withdrawal or care, never say there's nothing more we can do. There's always something more we can do. The question is, what is it? Let's not look at our phones, etc. And remember, even though you may have looked after hundreds of patients, for this family and this patient, this is a really important time, and there are no do-overs. We often need to listen more than we talk. So some of the other constructs that arose out of this reflected our residents' interpretation on why end-of-life care is so challenging in training, the sense of helplessness in the left panel, the inadequacy of education, the difficulty connecting with patients, especially in high-tech settings, and how the training systems tend to value knowledge and technical skills over other kinds of skills that are important at the end of life. So Three Wishes Project tend to reframe this a little more, acknowledge the key role of families, and help residents work on their emotional intelligence when they're so fixated on other types of intelligence. So this ended up being an important part of training in our programs in Hamilton, and helped residents do something tangible at the end of life. So what about this emotional intelligence? Well, I'll just give an example. Rounding on a patient as we were a couple of years ago, this was on the bed. And I'm sure many people bring in photographs and could be encouraged to bring in photographs. This was a woman who was dying, in her wedding album that her granddaughter had brought in. And there's a pair of boots on the bed. And when we walked by, everyone was wondering, wow, are those Nana's boots, or what do those boots mean? And they look like very large boots compared to this woman's feet. And in talking with the granddaughter of this patient, one of our residents asked the question, what is it? What are these boots about? And it was that awareness that led to conversations from the granddaughter saying that these are her dad's boots. And the father had died, and the granddaughter brought these boots, got the boots in to try to help her grandmother walk over to the other side. And there's stories like this that really, I think, highlighted the opportunity for developing emotional intelligence in everybody. So it tends to be a predictor of personal and professional excellence, and it's something that people can work on. Actually, it's all about recognizing and understanding emotions, and these four components, often referred to as skills, are about being self-aware, what's going on and how we are reacting in the environment, trying to help manage our own emotions, but being socially aware of what's going on, especially at the end of life, and trying to optimize relationships with patients and families, and sometimes other clinicians at the bedside. So over time, this Three Wishes project turned into sort of favorite part of my my practice, and a minor interest in my research. But we had a demonstration project, a research project to try to formalize it. Then it became more of a clinical program. We went on to multi-site evaluation, and as other centers began recognizing, yes, we do this already, but we'd like to do it more, and got sort of engaged in some of our retreats and conversations about all the tools. We asked, yeah, but is this a transferable sort of activity? Is it affordable? And we set some thresholds, wondering, especially because our friends in LA were going to participate, can this actually be done for less than, say, $50 for each patient? And it most certainly can. We had questions about the sustainability beyond the research phase. We all know how projects go on in the end, and then things just go back to the way they used to be. And is it valuable as interpreted through those experiencing it, and as recorded in interviews and focus groups? And we found that yes, in these centers in Toronto and Vancouver and LA and in our place, it is actually. And the relationships were those that were very important for the survivors left behind. So when we're seriously ill, when people around us are seriously ill, without giving this voice, we know that so-called existential questions arise about the purpose of it all, the purpose of this for each individual, whether it has any special meaning or etiology, what it means for those around us, what it means for our future life, relationships foregone, relationships broken, relationships of the future. And this idea that spirituality can attend to matters beyond the physical or intellectual and bring hope, support, peace, and comfort doesn't necessarily have to come from or have a genesis in religion. So Again, it was many years into my practice before I could string together 10 sentences in a row about spirituality. And that is aside from my own faith, but I really appreciated this one that is quite general and I think relatable. The aspect of humanity that refers to the way individuals seek and express meaning and purpose and the way they experience their connectedness, whether that connectedness is to the here and now, to oneself, to others, to nature. For a lot of people, spirituality is nature, and to the significant or sacred, however defined. And some aspects of spirituality were sort of religiously oriented or faith-based, but many are not. And as the project went on, people wanted to know a little bit more about it. We devised this schema, again, putting our sort of research hat on. This could be a clinical program, an interprofessional clinical program on the left, without any data collection or research ethics boards or funding. This just could be reflective of practice. Some centers interested in this with Model B have a clinical program and collect some quantitative data just to capture, to, for example, share for accreditation or to generate projects that may be of interest to write up. And the more fulsome research model would involve qualitative and quantitative data, possibly with interviews with families, not just clinicians. And in a hospice setting, even patients could be interviewed if the death is not too precipitous. So we thought about this from an institutional perspective, and one of the amazing members of the team, way too many for me to mention, but she got together to review some of the transcripts and recognize that projects like this can actually be illustrative of organizational compassion, which is a concept often in the business literature, but should be part of the conversation in the hospital, which involves this sort of triphasic collective noticing of what is going on. Shouldn't be hard at the end of life. Recognition of the pain and suffering, which is everywhere. It is in daily life. It is not just for dying patients. The collective feeling of what is happening. And the idea of responding in action, maybe words, but action as well through acts of compassion. And these pillars of organizational compassion, I think, are really reflective in our interviews. People, about the triple aim, and now there's quadruple aim, and of course now quintuple aim, but this notion of improved clinician experience was a little surprise to us about how meaningful engaged clinicians were when this became part of what they did. When we see moral distress and burnout, and we talk about it, resilience, we want to go beyond surviving to thriving. 3 wishes comes up in our community. The hospital leadership, interestingly, once interviewed in LA, Vancouver, Toronto, and Hamilton, came up very clearly. These are CEOs and managers being interviewed, talking about the obvious value to patients and families, if done authentically, of course, and sensitively, the value to clinicians, the alignment with institutional values, taking all those words, that are on websites off the page, if you will. And one might wonder, is this good for public relations of an institution? Well, sure, but that's not what it's all about. And often people want a business plan when something like this goes on. The insights from these interviews with managers was not about cost, really, but was about the balance of resources consumed, which are very minimal for some of the personal effects or tools or items, versus the value that it brings. So resources used versus the value that something like this brings. And these managers express to us, it's not a bottom line dollar figure, but it's evidence of value that they may look for. So honestly, if I look at the value of this project against the investment of resources, largely human resources, of course, it's hugely in favor of the value it brings, not just from a staff perspective, but a patient and family-centered perspective. Other simple acts that we've been engaging are sympathy cards. And this is very different than the condolence letter, and Haley will be familiar with this, a randomized trial from France, raising questions about condolence letters from ICU physicians, whether that is that harmful or helpful. In the context of a caring, compassion-oriented program like this, we send sympathy cards. Sympathy cards are not structured. They're not obligatory. They don't have the content outlined. They're invitational, where anyone looking after a patient who passed away is invited at coffee and condolence rounds. So they're just little cards put around in the lunchroom to pen a few words, personalized, and they are much appreciated. So the notion of the interprofessional practice, which is a buzzword that, at least in Canada, is used quite a bit, we're often struggling with what aspects of practice foster optimal interprofessional care. And this is certainly one of them, where there's this sense of a mutual purpose and respect. The context is clear, the consistency is clear, and the structure, even the name of the three wishes, has sort of helped to shine a light on practice that's already existing that may be like this, and encourage or empower others to do something similar and share stories. Because in the end, we are storytellers, human beings, and social creatures. And the communities of compassion are outside the ICU. Programs like this are contributed to by one of our collaborators, you can see in school systems, making comforting blankets so that we don't have the crispy off-white blankets on the beds of dying patients. And of course, people are encouraged to bring those from home. Along with France Clark, the research coordinator for this whole program, Ton Neville in UCLA, has been amazing. And she and her team have really underscored the meaningfulness of keepsakes or creations, and examining that which has gone on in multiple centers, including some community hospitals, considering how much these cost, which is very, very minimal, and excluding all the performing arts or the gifts that are pre-prepared and given to people. Just having a look at the different creations for $10 or maybe $20 or even less. These things have been underscored and grasped and held with passion by family members who take them home. And of course, not everyone is able to have all of these. Not everyone wants them. Obviously, it's a bigger endeavor to do some of these hand molds. Some people may be very grossed out by having the hair of their loved one in a vial. For others, it may be hugely meaningful. People write love letters. And over time at St. Joe's, our 6-year story is an example of something that began as part of practice, then a demonstration project, then a research project. Now it's a clinical program. And now it's much more an approach to practice, which doesn't necessarily need a name. And it has been a very good example for me about research programs, because I get asked to speak a lot about research programs, which are thought to be deliberate and methodical and logarithmic and planned in advance. And this is an example of something really quite different. So the engagement of patients in these institutions increased across the 3 phases. The wishes of patients and families increased because early on we found we were sort of giving the gifts, whatever they would be, to others, but the patient and family initiation engagement increased. And the frontline clinicians started to do this. So it wasn't the research team. This was sort of handed over, adopted and adapted by the frontline staff. So it became part of their practice. And this is how we went from the concept to the catalyst, or the champions, shall we say, and community, and eventually a culture change. So this brings us to the pandemic, stressful time for everybody. And I know just as a clinician on the front line, it was for everybody very exhausting. But I remember really being afraid of the loss of humanity at the end of life for patients with and without COVID in the pandemic. And we were encouraged to do another study by one of our internal medicine residents and France Clark and Neela Hode and Feli, the chaplain with whom I work. And we did that and had essentially through the same kind of mixed methods, 4 different findings. And we all know about the challenge of visiting policies. And I just want to go through some of these findings. So regarding not having the visitors present, or by the way, again, just calling the family members visitors, which itself is a problem. We found in this early phase of the pandemic that most patients did have a family either inside the patient's room or outside the room or outside the hospital from a window. And the families were present sometimes, but virtual visits, you can see that's a pretty low percentage, about 30%. And this was early on when video conferencing was not as well integrated into our system in the first couple of waves. And as we know, not everybody appreciates video conferencing. So this is just an example of something observed, not done by the doctor, but observed. We're able to turn the bed towards the window. The sisters were able to see each other and mouth, "I love you," and blow kisses right through the window. But honestly, it was one of the most gut-wrenching things I've had to watch. Regarding the PPE, obligatory, obviously, and there was a conservation method around PPE. One of the nurses said, "He's dying, he's coughing away," and all of us here are around him in this possible COVID room, dressed like aliens. Then we have to line him. I was so upset, just started crying in the room. It makes it a lot more complicated respecting the person. The third around clinician presence is one of the most fundamental things we can do as practitioners. And it doesn't always mean holding hands, it means being there. And it doesn't mean talking, it can just mean listening. You can see this quote from the resident really reflects his understanding that what he's being asked to say is the last thing that somebody's son is saying. Acknowledging you have to try and relay the full gravity of the message and the emotions the way it was supposed to be said. We found that family members who couldn't be there wanted to know everything, all the details, not of the medical care, but in this case, the setting, the physical aspects of the room, the name of the nurse who was looking after her, what was on her or in her, the visual image he was trying to conjure up. Just trying to imagine what it would be like for those deaths where separation from patient, from family existed. And the technologic assistance, if you will, that has been a boon in many ways, and will probably never go back to pre-pandemic when it comes to these connections. They have a dark side. We know about how it works well sometimes, but we also know it might not. A nurse recounting, I could tell that she was struggling so much setting it up because we were 40 minutes in and she just could not set up her iPad. It was during that time that he passed. Other people see their last view of their loved one technologically mediated through a screen. And the setup is imperative. So can we preserve compassion end of life care? Everyone, I'm sure around the world has tried to, and it's not been easy. But in this study in the context of the Three Wishes Project. The clinicians were inspired to learn each patient's story, adopt advocacy to try to fill the gap of family members, and initiate new ways to connect patients and prevent one of the socially violating events is an unmarked death. So amidst the COVID challenges we've all had, I think, hope, I know there have been many attempts, intentional practice attempts to try to preserve compassionate end of life care. And hopefully these lessons will carry us through. So 18 months ago, when we were at the end of the first wave, beginning of the second, our community had a pact to try to continue to honor personhood, use our clinical intuition, develop our emotional intelligence, and try to leverage the best way we can video assisted technology, but democratize it, check out with those receiving end and the giving end whether it is desired, and above all, try not to let our compassion become another casualty of the pandemic. Look forward to the conversations. Thanks.
Thank you, Dr. Cook. That was an extremely moving and motivating grand rounds. I particularly appreciated your approach of how you started with a idea, a demonstration project, and then rolled it out as a clinical program. And there was lots of conversations going on during your talk about the need for something here, and Dr. Gershengorn had a ulterior motive in bringing you here, I think, for a good reason, and pointed out some, as you pointed out, some very important aspects of the way in which we care for this very special group of patients. At this point, we have plenty of time for questions, and Dr. Gershengorn, I see your hand is up. Can you please ask our esteemed guest, Dr. Cook, your question.
Thanks so much, Dr. Weiss, and thanks, Dr. Cook, for coming. And Dr. Weiss is correct. I was messaging with him during this that part of the ulterior motive was already initiated by one of our hospital leaders who had interest in your project previous to this, but was re-inspired hearing you talk about it today and us thinking about how maybe we can bring something like this locally here. And so with that in mind, I guess my question for you would be, having seen this now roll out in a number of places and recognizing that hospitals and communities are different, are there things that a place looking to start something like this, even in either in a formalized way or not, should be open to in terms of barriers that you've identified or things that we might want to plan might be more challenging in one setting versus another?
Mm-hmm. Thanks, Haley. I think if there's interest and there's a will, it can happen. This is the sort of thing that doesn't really require, in my view, institutional approval, and as no data are being collected, no research ethics approval. But like the genesis of a lot of ideas, one way to begin is just seeing whether there are interested individuals already who have this as part of their practice or are keen to formalize what they already do and create a community with others to talk about how it might best start. And we began with, I just call them champions, people who like this part of practice. And we started to tell some stories and just do so pretty informally. We didn't even meet. And then, as you know, as an investigator yourself, there's nothing like writing something down. And our first document was 2 pages long. just trying to record, you know, what's the purpose of this, really, and have some sort of MO. So there's nothing to stop acts of kindness for anybody in hospital, anyone out of hospital, anyone in our life. But, you know, we thought we'd focus on people who were dying and try to conceptualize that as people who were going to have withdrawal of life support soon, or seems from the clinical team to be likely to die, 95% probability going to be dying soon, you know, that kind of thing. Just so we could try to focus in whom is this, for whom is this relevant. And with the champions, we did it a little bit, you know, like when you have a new something or other in your practice and you try it and you see and you make sure it's safe. But we did it for a little bit. And then with this document, we thought, you know what, it would be good to write down some data, just capture the patients. And we ended up doing some simple things of capturing as you would an audit, nothing too fancy, no big REB application. Just, you know, 4 or 5 pieces of data about the patients and documenting the wishes. And the wishes were on a simple piece of paper at the bedside. And so the bedside nurse would, you know, write down, you know, just got a T for Mrs. So-and-so, or, you know, something like that. And we had simple democratized approach to data collection, your average piece of paper at the bedside that people can, you know, come and see. And so we collected some pilot data. It wasn't even a pilot study. And then we said, okay, this looks great. How about trying to reach out to other interprofessional persons who might be interested? And we had a bit of a bigger protocol. So it was, it's not something that you can sort of mandate, like kindness can't be mandated or protocolized, but it's great to share an interest with others who may be keen to shine a light on it, formalize it just a little bit, and that could be enough. But if data are very compelling, and we found it desirable to sort of collect some quantitative data, just as we would with an audit, to be able to share. And then when we first did our IRB, or REB as we call it, we know the power of the story, the power of the narrative. So it was only 20 patients initially. And it sort of grew from there. But I think a shared purpose, mutual respect, an interprofessional team, the endorsement of the, you know, the champion, that is a great way to start for a lot of initiatives. And I think a little bit of data, even if it's going to not be sort of the full Monty research, a little bit of data is great. And the quantitative is easily done and is not effective, of course. The last thing I'd suggest is a cupboard, a little place on a step down ward, a medical ward, ICU, with supplies. So our supplies initially included flameless candles that can be reused, little vials that you saw, keychain, thumbprint keychains that can be made as keepsakes. A lot of volunteers in our community made blankets. Just things like that that could be viewed as easily identifiable and collectible items. And it just grew from there.
Thank you. Let's move on, Dr. Soares.
Thank you, Dr. Cook, for this great presentation. My question relates specifically the champions, and how were you able to identify who those champions were? And the second part of that question is, what was the training, or did you have any specific training that those champions went through specifically about communication? And were they later, when they became champions, were they providing that training to the other members of the team?
Great question. So in brief, when we started, our spiritual care clinician, of course, was very involved in this sort of activity. And a lot of the acts of compassion for her were around faith and prayer and, you know, objects and items and readings and rituals of a nature. So she was clearly interested. Myself, one of a friend of mine, a bedside nurse who's awesome. And I just used to chat with her about this kind of thing. And then the research coordinator with whom I work. And we didn't have any appointments or anything. We just invited people by word of mouth to be champion. And again, that it just kind of arose naturally. But as the project moved on, yes, we did have sort of training sessions through not scripts per se, but practice with the language that can be awkward. If people are, you know how there's a lot of very kind people, but they're not very great at verbalizing sentiment. So sometimes there are champions who wouldn't so much use their words, but use their action. They'd role model, you know, going to get things or making sure the resident would do something. So one of my friends, I remember for some lady who was dying, she had this idea, the patient wanted a piece of pizza and she'd been advised like not to eat for medical reasons. And she said, you know, can I go get one? He said, yeah, let's go. And they went down to the cafeteria and got this piece of pizza. And just the fact that he walked with her, you know, and spent $2. And I mean, that's nothing, but took it to her. And she said, you know, this is the most important piece of pizza I've ever bought. So that's just an example of a behavior. You don't have to call that person, the doctor, a champion. But there were natural leaders who emerged, and just like leadership, it's not a title. Leadership's an activity. Champions of initiatives like this also don't need to be, you know, appointed or don't need appointments. They just can be sort of encouraged informally. That's how we started initially, and then later it got more formal. You're right, Dr. Suarez.
Dr. Marcus. Oh, I'm sorry.
Thanks for that excellent talk. I was wondering if you could comment on differences in attitudes or approaches toward end-of-life care that you might have observed between Canada and the United States. Could be on a sort of the population attitudes or physician attitudes, or even like things that the government might do to encourage one type of, you know, behavior other than the other in terms of incentives for caregivers, et cetera.
Yeah, thanks. I guess the quadruple aim, that fourth aim, came up in our conversations with colleagues in the US, inside UCLA and outside. And the interest in the institution was a lot greater in the US than in Canada, I found. People looking for a jewel in the crown for their institution, or something special at a departmental level. We found more centers in the US were interested in what would be, you know, a great focus for perhaps fundraising efforts or for volunteer associations in a healthcare institution. And the managers were very, very engaged. I felt in Canada, there's a little bit more of a, you know, acceptance of things that we might like to do that would be nice for patients and families. So I felt there's a lot more institutional, frankly, interest in the US in this, which was great. We wondered, of course, whether there would be concern about the cost. But the persons interviewed and the leadership, especially our colleagues at UCLA, indicated that you know, as long as it wasn't extraordinary, this wasn't a big concern. Obviously, the differences between Canada and the US are, you know, there are, in a way, there are none and there are many, because it reflects so many different things. It's hard to make other generalized comment. Honestly, I just, two other sort of points of differences I might highlight is, for some communities, all the wishes are faith-based. but that isn't even necessarily like only faith-based. There's diversity within faith groups as well. But you know, there are some distinctions, I would say, that have come up, but honestly, I don't know that they're along the lines of the border.
Thank
So
you.
Okay.
I see no more hands, but let me thank you again, Dr. Cook, and challenge everybody as we turn off our Zoom cameras and turn off our computers for a moment to actually take 3 minutes and contemplate what we just heard, what we experienced over the last 2 years, and see how we each can make a change in the way in which we do our doctoring or our caring for our patients. Thank you so much for this great Grand Rounds, Dr. Cook. I know I'm going to do that for the next 3 minutes. Thank you, at least.
Thanks for your interest. And I know palliative care clinicians do this all day, every day. And I see that's been written in the chat, and absolutely true. Thanks for the invitation.
Thank you.